Assalamu alaikum. Welcome everyone on board. Um,
Walaikum salam wa rahmatullah.
yes, we have started the cardiovascular system, and today we will just try to, because majority of the things which we have discussed up till now are related to the general problems you may face while anesthetizing a patient with any cardiovascular disease. Okay, because any cardiovascular pathology, whether it is heart failure, whether it is ischemic heart disease or any valvular heart disease or any other problem, will result in either in the form of, will present in the form of either ischemia or in the form of failure. Okay, so same is the case with the valvular heart disease. Okay, so valvular heart disease, we discussed in detail about how to interpret an echo, and in that we discussed about concerns related to valvular heart disease, which we have to see in echo. Okay, because the how to evaluate a patient with valvular heart disease, usually if you just divide it into age related degenerative or rheumatic pathology related to rheumatic heart disease. Okay, usually, and these will be related to stenosis. Okay, and regurgitant lesions will be related to ischemia or prolonged in stenosis or critical stenosis, leading to a point when stenosis and regurgitation are combined. Okay, so usually there may be some other causes, other viral infections or other problems, but usually if we are talking about valvular heart disease, usually pathology we will be revolving around these things. Okay, and then usually, if for example there is combined valvular heart disease, then you will be focusing on the what is more severe. Okay, the what is more severe, you will consider it at that like that. This is another point. And another point is that, first of all, if you are trying to see the severity of the involvement in that valvular heart disease, you will be focusing on the same things which are there in any other evaluation for cardiac patient, in the form of symptoms, signs, investigations, all will be according to actually common for valvular heart disease. Severity will be in the form of either heart failure is has achieved or not, or the severity of according to the valve size, according to transvalvular pressure gradient. Okay, and regurgitant fraction usually, and then extra some points will be related to the presence of chamber clot, and because now some of the chambers are exerting more, so there may be hypertrophy or dilatation, and there is a stasis of blood, so there will be clot formation. When there will be clot formation, the concerns will be related to the provision of the patient receiving anticoagulants. So in this way, I have just tried to summarize. This is actually whatever we will be discussing later on will be revolving around these things. This will be related to the evaluation of the severity. And then the second step will be how to conduct anesthesia in those patients. Okay. So because usually that valvular heart disease patient can be there for an elective surgery, or maybe for an emergency surgery. Okay, so whatever question comes in the exam, you will have you have to divide accordingly in those two scenarios. This will be one thing. And if, for example, if there is emergency scenario, you cannot do anything, you cannot do any optimization, you just will be going towards a safe anesthesia, which we have discussed in detail in our preceding lectures, in which we just focus that what are the, how will you be monitoring, how will you will be giving fluid, how you will be giving the analgesia, how you are monitoring in addition to standard 1 and standard 2, you are doing cardiac monitoring, okay, in the form of invasive blood pressure monitoring, in the form of monitoring the filling pressures, okay. So this is, of course, maybe who have not attended our previous discussion may be unable to catch my words, but who are following us, you can review recordings are available, so you can follow them, okay. So usually this, but I have just summarized what are the important points, okay. So in the conduct of anesthesia, one thing will be managing a plan which is safe, number one, and number two, there will be some goals which will be related to stenotic lien and some goals which will be related to regurgitant lien. Usually for stenosis, we say you have to keep the patient slow and tight. Slow and tight. We will discuss what is so slow and tight. And if you are talking about regurgitant lien, we have to keep the patient fast and loose. So this is the basic. And now we will start. So who wants to take the lead? Sumera? If you just revise some of the points related to severity, for example, if we focus on stenotic liens, mitral stenosis, and aortic stenosis. So, how to, can you just recall the numbers of the valve size for stenotic lien in mitral and aortic?
Ji, sir.
Yes.
Sir, if we talk about mitral stenosis, first we will see the normal size of the mitral valve. The normal size is 4 to 6 centimeters square. And then we, on echocardiography, we do the grading of the severity, like it is mild, moderate, and severe.
Okay.
In a mild mitral stenosis, valve area is 1.5 to 2 centimeters square. In moderate, it is 1 to 1.5 centimeters square. And in severe mitral stenosis, it is less than or equal to 1 centimeter square.
Actually, don't be distracted by the numbers. Maybe usually in some books you will find that less than like if the diameter is more than 2, there will be minimal symptoms. Okay, just to make it simple. If it is less than
Yes.
2, more than 2, there will be mild symptoms, and then less than 2, between 1.5 to 2, and then 1 to 1.5, and less than 1. Some people will say less than 1 in some books. It is written 0.8, something like that. So usually it is a little bit different, but usually you have to understand what is mild, moderate, severe. Okay, this is one thing. There is one more thing which is not written here. What is that thing? Transvalvular pressure gradient. Okay.
Yes, sir.
So this is more important in the case of aortic stenosis, because that is the pump which is pumping that is related to the pumping of the blood to the whole body. So that is the we are considering it, I think, more over there, but you can consider the transvalvular pressure gradient here as well. Okay, this is one thing. And then if you can just recall what will be the sequence of events if there is mitral stenosis, what will happen in chronic patients, and in what happens in acute decompensation, and what happens?
Sir, usually if there is a mild stenosis, patient remains asymptomatic, and as with the passage of time, as disease progresses, patient may present with fatigue, dyspnea, and symptoms of respiratory system. And with the passage of time, patient may develop pulmonary hypertension. First, the patient will develop dilatation of the left atria, and then if it progresses, then it will then patient develop the pulmonary hypertension.
Okay, so there is a this one there is stasis of blood. Okay, and because the door between the left atrium and left ventricle is fixed. Okay, so any change in the blood volume will significantly affect. That's why For example, if that's why I told that in stenotic lesion, you have to keep the patient slow and tight. That is the reason that if the heart rate is getting more, the filling time, which is already hampered, will further decompensate, and the patient will not be able to maintain the cardiac output. Similarly, if there is significant decrease in SVR, the perfusion pressure will not be able to be maintained. Okay. So this is what the theory is. And as the another thing, when you told about left atrial dilatation, there is one more point about presence of atrial clot, and one more thing. What is that?
Left ventricular dysfunction.
Uh,
No.
pulmonary
Dr. Humera,
hypertension.
no. Please, Sumera, just finish it. Sorry, you are unmute yourself, please. Related to atria, I'm not talking about ventricle, Dr. Humera. I'm talking about atria. There is something else related to atria, which is important.
Dilated.
Increased left atrial pressure.
Please say again, Dr. Mai. Say again, please.
Increased left atrial pressure.
Increase left atrial pressure. This is one thing, but what is the result? If you
Hypertrophy.
Thromboembolic manifestations.
Thromboembolic manifestation is important. Another thing, you are not coming to the point.
Are you talking about the arrhythmia, sir?
Yes. Like you see, we have
Yes.
discussed this. We have discussed this before, that filling of the heart occurs in 2 steps. We have discussed in detail. If you want to just review the discussion related to echo. Okay. So in that we discussed that there is one is passive filling. Okay. And one at the end, which is labeled as E for elephant in echo. Okay. And other is A. Okay. So A is related to the atrial contraction, which occurs at the end. And as much as the severity of mitral stenosis occur, this atrial contraction becomes more and more significant. Okay. That's why there is a chance, there are more chances of patient going to atrial fibrillation in this patient. Okay.
Yes, AF is very important. Yes.
So if patient goes in atrial fibrillation, maybe any other patient is able to tolerate it. But because the normal contribution to cardiac output is around how much?
20%.
Yes. So it becomes more and more. Okay. So we discussed about E over A ratio. And we said that as much as E is decreasing and A is increasing, the heart is sinking in something bad. Okay. So that's what they have written here. Whatever we have discussed, some of the points. And if the back pressure is going back, there is the pulmonary vasculature, which is not tuned for high pressures. They develop hypertension. And then next step will be the failure of the right ventricle. Okay. Because right ventricle is not tuned to have high pressures. So that is the theory which occurs in mitral stenosis. If the same patient if you give more fluid in acute condition, there will be pulmonary edema. Okay. And in chronic cases, there will be pulmonary hypertension. Infections. Yes. They're like, usually it will be having the signs related to left heart failure. And later on, the signs of right heart failure will also be there. Okay. So according to the scenario, according to the severity, that's what I'm telling you. There is no distinction. Okay. Any cardiac patient can have mixed picture. Okay. The same patient will be developing right heart failure later on. Okay. So this is some of the MCQs they can ask you, that the soft rumbling diastolic murmur which occurs in mitral stenosis. Okay. And this is maybe they will also ask Mahler flush because of back pressure. The same thing will be occurring. And this is the finding in the ECG and in echo. Maybe like if severity is not too much, maybe only the valve size is significant. Later on, transvalvular pressure gradient is increasing, then the valve self is getting more and more down, and then this failure will ensue. Okay, so this P mitral high amplitude P wave because of left atrial enlargement. Okay, and what else? Double shadow behind heart on PA film in X-ray. This may not be there in every patient. If you don't forget these things, this is more important, that a patient with mitral stenosis, if it is not symptomatic, X-ray may be normal. Okay, but these are the findings which may be there in different patients. Failure, signs of failure. Okay, so that's what I
Sir,
was
what
telling.
is EA ratio is reversed? What is meant by this?
Dr. Humera, we have discussed in detail. Okay, if you want to review, you can see the YouTube video. Reversal is that usually passive filling occurs without contraction of atria in the start. That is, we label it as E, passive filling of the heart. And for that, the pressures in the left ventricle are optimal. That's why that it is that phase is isovolumetric relaxation. So if also in isovolumetric relaxation phase, heart is relaxing normally, there will be ease of blood coming from the left atrium to the left ventricle when the mitral valve opens. Okay, but in this condition, what is happening, that because the door is not opening properly, so there is no passage to come very quickly. So the dependence on the later phase of the diastolic filling, which is due to atrial contraction becoming more and more dependent. Okay, and even despite everything, there is still something remaining in the left atrium. So left atrial atria are dilated. So gradually, what is happening, that the diastolic dysfunction is occurring because heart is getting hypertrophied. Okay, when heart is getting hypertrophied, left ventricular and diastolic pressures are getting higher. So this is a vicious cycle which is going on in this mitral stenosis. So this is reversal of E over A ratio. Okay. Okay. So in the conduct of anesthesia, as I discussed, we have to keep the heart rate in the low range, avoid tachycardia, and we have to maintain avoid all the medications or all the steps. So the critical step will be induction of anesthesia, airway manipulation. You have to maintain the heart rate at that time using or use of opioids other than tramadol and pethidine, which are causing tachycardia. Okay. So what else? Any medications which can cause, like ketamine. If there is hypotension, you have to use which medication?
Etomidate.
Dr. Humera,
Phenylephrine.
please, before answering, you have to think what I have asked. If there is hypotension, what medication would you like to give?
Sir, we will choose phenylephrine.
Phenylephrine, not ephedrine. Okay, we will not use ephedrine because ephedrine. Why? What is the problem? That because it has direct effect like phenylephrine, and it has indirect effect via release of catecholamines. So we don't want the release of catecholamines in this scenario. Okay, because they will prone the patient to arrhythmias, number one, and it will cause tachycardia. So this is the reason for it. And etomidate, you told rightly, this is for induction of anesthesia. Okay, for induction of anesthesia, if you compare between any other induction agent, it is better to use etomidate if you have heart failure. Okay, because there are other serious problems related to etomidate. What are those? This is how you just revise your subject. Yes, Sumera.
Sir, adrenal suppression.
Adrenal suppression. What else? This is one. What else? Myoclonus. Okay. Myoclonus. So etomidate is actually not a very good medication, but practically in the exam, you have to tell that whenever there is cardiac depression in this scenario, in other patient in shock, you are saying ketamine, but here you cannot say even ketamine. Okay. So you will be doing, in addition to standard 1, standard 2 monitoring, you will be doing the, what monitoring you will be doing?
Sir, other than standard 1 and standard 2 monitoring, we will use the invasive arterial blood pressure monitoring. And we can also use CVP.
Okay, what else? CVP, and why you want to do CVP? In exam, you, rather than they asking you question, you can tell to monitor the fluid status, to give the meticulous fluid, and this is one thing. Number 2, to give inotrope or vasopressors if needed. Okay. CVP reliable in, is CVP reliable in valvular heart disease patients?
No.
Sir,
Why?
no, it's not reliable. Sir,
Why?
like if there is a mitral stenosis and there is right ventricular failure, like back pressure of the blood, so it will not be accurate.
Okay. So you cannot pick the fluid status, actual fluid status, even if CVP is high, maybe patient may be fluid deficient. Okay. So then what will be the ways to monitor the fluid status?
Urinary output.
Okay, one thing. What else?
Pulmonary catheters.
Pulmonary artery catheter. Pulmonary artery catheter will also be not accurate. What else?
Sir, we can check the inferior vena cava compressibility.
This is one thing. What
Capillary
else?
refill.
What else?
Stroke volume variability and pressure volume variability using transesophageal echo.
Yes, this is more important. Okay, this is more important that you have to stroke volume variation will give you a better idea if you are monitoring the cardiac output by non-invasive way. That will be giving you a more detailed information about the volume status of the patient by giving the lung water. I'm not very good at it, but actually they give very detailed information about the total lung water. I'm sorry, I cannot recall all of them, but pulmonary is this one, cardiac output monitors, or even if you are only monitoring through invasive blood pressure monitoring,
yes,
there are
line.
arterial line, it will give you a better information. Okay, that will be more reliable. So you just have to, because with the arterial waveform, you can even target the systemic vascular resistance. Okay, how can you pick, Usman? If that SVR
sir,
is going down?
Sir, that diastolic notch, its position, it's either on the upward side or the lower side, at the base or at the top. We can.
So if it is
have
very down, it means SVR is?
Very down, it means the SVR is more, I think.
Yeah, I always forget this thing. I'm not very
yes,
good. I always forget this thing. Anyone who knows about it, that the place of dichotic notch tells us about the systemic vascular resistance, whether it is top or bottom. You can see. Okay, because this will also stroke, this one arterial waveform will tell you about the how is the contractility. Okay, how is the SVR. Okay, so it is easy for you to monitor these things. And then yesterday, which we discussed, our best friend, normoxia, normocarbia, normotension, normovolemia, normothermia. Okay, because all of the things which will be putting stress on the heart. Okay, because they will be stimulating the sympathetic system, so you don't have to let it happen. So actually, if you forget, if you remember these things, you will be able to, because you don't need to say that we have to keep bradycardia. It's not bradycardia. Okay, you have to keep the heart rates on the low normal. In some books, you will find 60 to 70, some things like that. I don't agree with 50. I think it is better if you say low normal, or you say 60 to 70. 50 is, I think, too low. Okay. Anyways, so this is all about. So now another question comes between choice of anesthesia between epidural, spinal, and general anesthesia. So how can you compare these three in patients with mitral stenosis? Yes. In which patient, which will be preferred? Sorry, yes.
Sir, in stenotic lesions.
Just a second, Sumaira. Just give me a second. Just let that person who was talking. You want to speak out, please.
Sir, top choice, most priority choice will be GA, sir, in stenotic lesions.
Okay, why?
Sir, we have to because of slow and tight, sir. In spinal anesthesia, there will be a SVR will be decreased, sir. That's why we will go for GA, sir.
Okay, so I think you have to become like a politician. Okay, because if you say that GA is better and I can achieve the goal easy, and the examiner can catch you, that the answer should be starting that there is no safe, because you have a lot of problems in general anesthesia, and there are a lot of problems with the central neuraxial. Okay, and it is not the choice of anesthesia, it is the conduct of anesthesia, how you do. That is more important. Okay. Yes, you can say that in general anesthesia, you can control the targets if you are able to control the critical points. Like critical point will be laryngoscopy. Okay. Critical point will be extubation, intubation. Okay. So if you are able to control those critical points, maybe you are able to control them. Tell me one thing, same person, please. Just tell me one thing. What is the effect of inhalational agents on SVR? Yes, please.
Sir, depend upon the inhalational, like SIVO, it's like isoflurane.
Okay.
It will decrease the SVR.
All of them, except there is only one which has less effect on SVR. What is that? Inhalational, and that is not used now actually.
And
no,
sorry,
Halothane.
Halothane. Directly myocardial depression, that is Halothane, not effect on SVR, sir.
Yes. Okay. So the examiner will say that, what do you think that inhalational agents are not affecting? They are saying that because we are in a patient with valvular heart disease, we should not decrease SVR. What do you think? Okay. So actually, yes, GA, we use it because we can optimize the conditions in a better way. Okay. So still, you have to be very careful. You have to maintain.
It also depends upon the severity of the stenosis. If there is mild stenosis, then epidural can be given.
No, that's what I'm trying to say. That even yes, Usman. Now you answer, please. Tell me one thing. Would you like to give epidural even in patient with severe mitral stenosis? Would you like to use it as a combination?
Yes, sir, can be, but I think it requires some experience. Can be given with a slow dose of local anesthesia with opioids.
Yes.
Can be given epidural, but you need a lot of experience for that. For a newcomer, I don't think it's a very good idea.
No, I'm just telling you that in the you just should have a concept while answering, or even that what will be the use of central neuraxial block. There is another thing is that because these patients are taking anticoagulants. Okay. So you have to optimize the dose of anticoagulants. Some patients are also taking even warfarin. Okay. So if the patient is on warfarin, then even for the things other than hemodynamic, you cannot give in emergency. Okay. And you have to do the risk versus benefit. That what are the, because there are a lot of advantages if you are using epidural as analgesic only. Okay. If you are using only 0.06, because analgesia can be achieved even with 0.0625, like minimum 0.1%, which have very less effect on the sympathetic
autonomic system, hemodynamic. Yes.
Okay. So that is the point which I am just telling you, that just try to say that because it's a tricky situation and the goals are more important and the conduct is more important. Okay. So yes, there are some problems related to central neuraxial and there are certain problems related to GA, and we just have to monitor the patient in a very nice way. And we have to, whatever we are using, you have to be using it very carefully. Okay. Like there are, again, we will just put it all the steps which we follow, the conduct of anesthesia, like pre-medication, optimize it, because in elective patient, you will be optimizing. Elective surgeries will not be done unless there is a strong indication, or for example, if the patient is decompensating, any signs of decompensation are occurring, then it is better to do the valve surgery before that elective surgery. Okay. But cholecystectomy is not a purely elective surgery. Okay. So here you can say that you will have a multidisciplinary team discussion. Okay. And you should be outweighing risk versus benefits. And because of course, some surgeries cannot be delayed, and some surgeries can be like for example, if a patient has mitral stenosis and it is moderate to severe, and now this patient is also having osteoarthritis, and now they are planning to do the knee arthroplasty. Okay. It is better to do the valve surgery first. So that is the concept, but it will not be your decision. You will be saying that you will be discussing in multidisciplinary team, surgeon, cardiologist, and discussion with the patient. And then you will chalk out the plan. Okay. You will be targeting the reversible components. Okay. You will be using some diuretics, inotropes. Okay. And another thing is that these days, some of the valvular procedures, they being done by endovascular.
Percutaneously.
Yes. Okay. These are the endovascular procedures. So they are less invasive. Okay. There is a name of the procedure is that, have you heard of TAVI? This is transaortic valve implantation, transthoracic aortic valve implantation, TAVI. Okay. So you have a number of ways to manage it. Okay. So I understand, please, everyone.
Yes, sir.
Okay, Sumera, anything we have missed? Because the thing which people start, I remember the days that I used to read these lines more than anything else. Even if you are reading a book, you will be telling rheumatic fever, this. This is the least important thing. Okay. Etiology may be anything. Yes, they will be asking you the etiology, but you should be knowing that it is a long history, and patient may have some rheumatic fever, and later on after 10 to 15 years, they are presenting like that. Okay. So you see, if I just say that we will do the aortic, just a second. I think we will have to do it in 2 sessions. It will not be able to, because there are so many things when I start, I'm unable to control the discussion. Okay. So I think we will divide it. What should we do? Just a second, please. Aortic stenosis. Where is aortic stenosis? Okay. The majority things which we have discussed are the same here as well. Okay. There are some difference in the valve size. It is relatively smaller. And usually symptoms, again, it is symptoms again. what is the common thing? That symptoms occur after 2 centimeter, usually here as well. Okay. But the size, the critical is less than point. Some books you will find 0.6. In some book you will find 0.8. Okay. And here the critical is this transvalvular pressure gradient, more than 50. Okay. So in addition to the things which we have discussed, because some of the features will be the same. Okay. Some of the pathology will be the same. Because, for example, if what will be the sequence of event in aortic stenosis? Who wants to tell? Samira, please tell.
Sorry, in a mild condition, like a patient may be asymptomatic, but patient may develop dyspnea, chest pain, and syncope.
Mm-hmm.
And as with the passage of time, as the disease progresses, patient may develop left ventricular hypertrophy.
Okay. It is written here, but why?
Sir, left ventricular hypertrophy?
Yes.
Sir, due to aortic stenosis, left ventricle has to push the blood against high resistance.
Yes.
Like,
actually, if you just think,
increased.
almost similar thing occurs in hypertensive patients. Okay. Here the door is problem. There the passage after the door is problem. You understand that there SVR is more in hypertensive patients. So there is left ventricular hypertrophy, and here the door is closed or not properly opened. Okay. So it's the same theory occurs here. So when there is left ventricular hypertrophy, there is increased left ventricular end-diastolic pressure. So the same thing occurs again, that atria need to contract more and more to fill the heart. So this actually, it's the same sequence of event. And then the back pressure is going to the lungs. We don't need to repeat it again. It's the same theory which occurs here. A little bit of difference, and the symptoms will be similar to angina and syncope. Okay. Because if severe occurs and patient is unable to maintain the cardiac output, patient okay. So similar is the rest of the things are the same. Same transvalvular pressure gradient, same valve size. Symptoms are a little bit different. Symptoms are more severe maybe here. Okay. This is slow rising pulse with narrow pulse pressure. Okay. The diastolic pressure is more. Am I right? And there is ejection systolic murmur. Because if the door is closed, not opening properly, while the systole occurs, it is going against resistance. So that's why ejection systolic murmur occurs. Okay. And signs of failure, left ventricle. If you think that, for example, if they ask you, what are the ECG changes in aortic stenosis, don't be afraid. There will be maybe here, they have not written here, but maybe it is because of any ischemia. Okay. Maybe ischemia is occurring. So there may be ECG changes, maybe because of ischemia, because of hypertrophy. Okay. So there is nothing so special you need to remember specifically for aortic stenosis, because when they ask, you think that there is something out of the world separate for it. It is not like that. Okay. So what else? Perioperative care, almost the same things. Nothing need to be the same thing which we have discussed. Maintain sinus rhythm, adequate volume loading, high systemic vascular resistance. Actually, it is they have written high. It is better to say that you have to maintain the normal systemic vascular resistance. You don't let it down. Okay. If you make it too high,
high
what will
normal
happen?
High normal.
High normal, or for example, you can say you have to maintain it. Okay. Because if it is going down suddenly, the blood pressure will not be able to be maintained. Okay. So they have the same fixed cardiac output, same thing. Actually, if you understand, then it is very easy to explain. If you don't understand, then it becomes very difficult. Okay. Same things have written, how to do the monitoring, fluid balance, CVP, esophageal Doppler, T, as we discussed before. Okay. So if there is, and in all these patients, you can tell that you can keep cardiology on board. You can put the defibrillator pads. Nobody can say that it is unsafe. Okay. If there is availability, you can do it. Okay. So these are the things, the same HDU monitoring, which we discussed before. Okay. So I think we will have to do it in 2 steps. It will not be possible for me to finish all the points related to it in one session. Okay. So any questions up till now? You understand what we discussed?
Yes, sir. So can we discuss here the pressure volume loops?
I think we will discuss tomorrow. Okay. Because majority of the portion we have covered. So tomorrow that portion which you had prepared, we will discuss, and then the regurgitations. Okay.
Okay, sir.
Thanks a lot, all of you, and inshallah we will do it tomorrow. Bye bye.
Thank you, sir.